And now I have the great pleasure to introduce Dr. Laskari, who will present the role of preoperative echocardiography in congenital pulmonary valve anomalies.
Thank you so much, Professor Karagos. I'm very honored to be invited in this first International Congress of the Balkan Society of Pediatric and Congenital Heart Disease. My talk today is going to be the role of preoperative echocardiography in congenital pulmonary valve anomalies. As Professor Anderson said, the pulmonary valve guards the RV outflow, is a tricuspid semilunar valve, congenital anomalies of the pulmonary valve consist of pulmonary valve stenosis that are really thickened leaflets and narrowed orifice, pulmonary atresia, pulmonary dysplasia, which involves a very bulbous and irregular valve with very thick leaflets, tetralogy of Fallot, and the absent pulmonary valve syndrome. So why echo? Why do we have to do echo before surgery? First of all, because echo is non-invasive. It is obviously real-time. It involves no radiation. Εγώ πάτησα κάτι. Εντάξει. It involves no radiation, and it is the only real window in fetuses and neonates, and it can also map valve morphology, valve gradients, and RV function. It can guide timing and approach of intervention. So what are the key echo findings when we look at the pulmonary valve? So here we can see a pulmonary valve that is really very dysplastic. This is an echo view. All the leaflets are really thick, and the opening is very narrow. We can use color Doppler, which involves, over here we see a turbulent jet across the valve, and M mode to assess RV wall motion, and also 3D echo if it is available, to look at the annulus and do more specific annular measurements, as Dr. Anderson said in the first talk. So with Doppler imaging, we use both continuous wave and pulse wave Doppler. If the peak velocity is more than 4.5 meters per second, which is 64 millimeters mercury, this is severe pulmonary stenosis. If it's less, then it's either mild or medium pulmonary stenosis. Also, we look at the color jet across the pulmonary valve. If there is a blue to red aliasing, then it's obviously turbulent jet. And we can assess by echo the regurgitation jet. We can see if it's mild or severe. So there are 3 echo views to assess the pulmonary valve. The right ventricular outflow view, which is the first view, the parastellar short axis view at the aortic valve level, and the subcostal view, which is also very, very useful. The challenges of echo imaging are that there are only 2 valve leaflets that can typically be seen on transthoracic echo, and not 3, as obviously it's very easy and very common with the aortic valve. So it's really very difficult to image all 3 leaflets of the pulmonary valve, and in some cases it can be done, but it has to be a very tilted view from way up, looking down. Also, there is lung tissue interference that limits the image quality, and the valve anatomy, most of the times, is difficult to confirm because we cannot identify leaflets with certainty. It's very uncertain which leaflet is which a lot of the times. The pulmonary valve is usually thinner than the aortic valve. The leaflets are thinner due to lower right-sided pressures. So visual inspection alone is unreliable for determining the number of cusps and diagnosing sometimes mild forms of disease. So the first suspicion is if somebody is looking at thickened cusps, and this can also be seen by M mode, that you can see a very echo-bright image there. Pulmonary valve stenosis, there are several types of malformation. The most usual ones are the dome-shaped valve, which is 40 to 60%, and its commissural fusion creates a narrow funnel-shaped opening. Dysplastic, which is 20 to 30%, thickened valves, and pulmonary atresia, which the valve usually fails completely to form. In pulmonary stenosis, we use all three views, the parasternal tilt view, the parasternal short axis, and the subcostal view, and continuous pulse wave and color Doppler. Now I'm going to show you some examples. This is a mild congenital pulmonary stenosis in a neonate that just born. It's like 2 weeks old. It's a very mild stenosis. You see that the valve leaflets are really thin, not very thickened. The gradient is only 20, and one can measure the annulus of the valve using 2D echo. In the next image, we see congenital pulmonary valve dysplasia. This is also a neonate 2 weeks old. And you can see the difference between the valve leaflets comparing to the previous valve. I don't know why the color is not playing, but one can also look at the turbulence through the valve. And the gradient here is it's close to 50 millimeters mercury, which consists of medium pulmonary valve stenosis. It is not above 65, 64 millimeters mercury, so it's not time for intervention yet. But this is a picture of the valve that probably is going to need intervention in the future. Another image of a child with Noonan syndrome and a very dysplastic pulmonary valve who is now around 6 years of age and had no intervention so far. The valve is dysplastic, probably bicuspid. The gradient used to be very close. It was always for a long time around 60, 64, so it was really, it was very difficult to one could go either with intervention or not, but the family chose to wait and see what happens. And actually now there is still a dysplastic valve, as you can see in this first image, but the child had no intervention so far. She may need it in the future. Another child with Noonan syndrome and dysplastic pulmonary valve who had a neonatal balloon. In these still images, one can see how echo can be very useful in assessing the peripheral pulmonary arteries. In this image, you can see how big is the left pulmonary artery because of the preferential flow of the jet of the pulmonary stenosis towards the left. Usually, as everybody knows, the left pulmonary artery is a little bit smaller than the right, but in this case, it is not, and one can see how echo can be helpful assessing that. Another entity that echo can be very useful with is tetralogy of Fallot versus double outlet right ventricle. In this particular case, which is tetralogy of Fallot, but one can argue that probably it is a double outlet right ventricle because there is no infundibulum, there is no conus between the aortic valve that you can see. I don't know. Yeah. That one can see there, and the pulmonary valve. Yes.
If you would like to show with your finger, because it doesn't function with the screen. Show with your finger.
Yeah.
Go to the screen.
So, yeah, this is the aortic valve, and this is the pulmonary valve. Usually in between the aortic and the pulmonary valve, there is some muscle, infundibulum or conus. Here there is absent muscle, so this is probably a case of double outlet right ventricle with absent infundibulum. One can use echo for risk stratification. One can assess RV dysfunction, which consists of higher perioperative risk. Now, these are supposed also to play, there's moving images, and RV hypertrophy. One can assess tricuspid regurgitation, as in this case, hypoplastic PA branches, and a VSD with or without shunt. Okay. It's okay, we can move to the next. It's okay. In terms of risk stratification, the echo flags are if there is critical stenosis, the baby or the patient needs urgent intervention. If there are associated defects, VSD or ASD, that changes the management. And if there is RV dysfunction, this poses a higher perioperative risk. Okay, this is a Noonan syndrome with pulmonary stenosis after surgical valve replacement twice in the past. One can assess that how bad, how poor the right ventricle functions. Really, the right ventricle is has very low shortening fraction and ejection fraction. And this is a high-risk procedure, especially because this patient also had arrhythmias. As you see on the second slide, there is she had a defibrillator placed in for severe ventricular tachycardia and arrhythmias. And this patient also developed symptoms, and she needed a third valve replacement, which she had. One can assess, as you see here, how thick the valve is, and it's not really moving so much. It's low flow, low gradient, and this is the valve of the same patient. You see that it's not moving at all. The leaflets are thick, echo bright, and do not really move. This is another patient with a trilogy of Fallot after pulmonary valve replacement and a pacemaker. And this is the result. One can assess the pulmonary valve, but you can see that even though there is no gradient, there is no, the patient does not need another intervention as of now, that the valve leaflets are not moving that much. That poses one of the limitations of the echo, because you cannot always see if it's a thickened annulus, thickened valve. You cannot assess valve leaflet motion. Okay, so another patient with a trilogy of Fallot with replacement of the two valve replacements in the past. And now this was an adult who actually is kind of big guy, tall guy, but he had a homograft, which probably was a little bit small for his size, because immediately post-op he had these images, and then the gradient immediately post-op was close to 60. So even though people sometimes try to put homographs, which are supposed to be really good for pulmonary valve homographs for long-term viability, they have to be the right size. Obviously, this patient had an improvement of his symptoms because he had pulmonary regurgitation in the past, but this valve may need also replacement in the future. So one can assess the PS velocity thresholds. Usually the normal valve velocity is around 1 meter per second. Mild stenosis, peak velocity is around up to 3 meters per second. And severe stenosis, the peak velocity is more than 4 meters per second. Echo can be used to differentiate valve versus outflow tract stenosis. Increased velocity may not always originate from the valve itself, but it may originate from the subvalvular tissues, like the right ventricular outflow tract narrowing, as in tetralogy of Fallot, or in other cases, as in a double outlet right ventricle or double chamber right ventricle, or it can be supravalvular be associated with pulmonary artery stenosis. The pulse wave Doppler identifies the point where the velocity increases, which is the step-up point. It differentiates valve-level stenosis from other causes, supravalvular or subvalvular. And the color Doppler also can help in the anatomical level of the narrowing. So let's go to interventions. Echo can help with deciding what kind of intervention is going to happen next. The most common intervention is balloon pulmonary valvuloplasty, which is the first-line treatment for moderate to severe isolated pulmonary stenosis. It is very safe and effective and reduces valve gradient and improves symptoms, especially in neonates. If one cannot perform valvuloplasty or if multiple valvuloplasties are not successful, one can go next to surgical valvotomy. But surgical valvotomy is a very nice technique that there is a prerequisite that the valve and annulus are not significantly malformed. Otherwise, if they are significantly malformed, one has to go to pulmonary valve replacement. And usually this is performed the trilogy of follow-up patients after the first surgery that they develop severe either stenosis or regurgitation and right ventricular dysfunction, and usually one goes to pulmonary valve replacement. This is a patient with neonatal pulmonary stenosis, severe, and kind of hypoplastic right ventricle. I don't know why this is not, because this is actually a very nice image showing a small RV and severe pulmonary regurgitation. I don't know if one can make it play from... It is? It is? Not? Okay. It's a pity because actually they are videos, but it's okay. One can see here the same neonate who has a very hypoplastic RV, and over here one could see that there was pulmonary atresia, almost pulmonary atresia. In the next slide, we can play it now? How do I escape? Ah, okay. Okay. So one performs a valvuloplasty through the pulmonary valve, and in this particular patient, after surgical valvotomy, one had to perform multiple valvuloplasties in order to do sequential depressurization of the right ventricle and sequential improvement of the right ventricular outflow output. In this particular patient, one can see the BT shunt, and it's a pity it does not play because it's actually very nice images. One can see how beautiful this, over time, the same patient, the right ventricle is not that hypertrophic anymore. It developed a little bit more, not that hypoplastic and not that hypertrophic. And if in the last image, the tricuspid regurgitation that used to be huge right after birth, now it's very, very small. So we had a nice result with that. I think all images don't move anymore. This is a low flow, low gradient PS. The right ventricular is not moving at all. It's moving now. That's just a quick mention to Epstein's anomaly that can lead to functional or anatomical pulmonary atresia. And also one can use echo for fetuses, of course. It's the gold standard. One can see the pulmonary valve over here is very thickened. Let's see. I'm sorry, I have a lot of videos, so maybe just... Εδώ. No. Yeah. Αν δεν παίζει, δεν πειράζει να πάμε στο... Ναι. Αυτά δεν παίζουν. Παρακάτω, παρακάτω. Πιο κάτω. Εντάξει, δεν πειράζει. Δεν μπορεί να παίξει, έτσι δεν είναι? Δεν πειράζει. Ας πάμε στο επόμενο που θα είναι η τραϊκάσπη. Και εδώ πέρα το fetal. Στο fetal το είναι εδώ. Η βαλβίδα. Η πνευμονική βαλβίδα είναι εδώ και κανείς μπορεί να δει πώς έχει το έμβριο και στένωση και ανεπάρκεια.
In English.
Oh, I'm sorry. Sorry. One can assess the pulmonary valve stenosis. It's a very thick pulmonary valve in the fetus, and one can assess also the gradient, the stenotic and regurgitation gradient. Next, please. I do, but I don't. Έχει μπαταρία. Εδώ, το επόμενο. Το πριν από αυτό.
Το πατάτε αυτά τα κάτω,
Ναι,
κλείνει.
ναι, δεν τα πατάω.
Αυτό.
Ναι.
Ή τα βελάκια μου.
Okay.
Ή δεν ξέρω αν είναι...
So these are more images of fetal echoes with PS. One can assess the pulmonary valve very well with fetal echo. Of course, there are some limitations to echo that are poor acoustic windows. MRI comparison, which is obviously much better, as you can see very clearly the pulmonary valve, it is bicuspid or not, and pulmonary regurgitation jets. And echo cannot always predict post-op outcomes. So in conclusion, preoperative echo is the gold standard first step for evaluation of the patient, and it shapes surgical plan, which is either balloon valvuloplasty, open repair, or conduit repair. It usually saves time and cuts surprises. Thank you.
Thank you, Dr. Laskari. Really very nice presentation, very rich in imaging. Now we will